While we're waiting on that, we'll get through some of the material in the slides. So this is outpatient based. It's transrectal.
No, that's not the right talk.
And this is done in bore in a 1.5 Tesla MR system. It's a phase 2 trial. We've got 161 patients, 255 cancer foci that we've treated so far. The inclusion criteria are basically grade group 2 patients, but also large volume MRI visible grade group 1 patients. So by large volume, we've defined that as 1.5 centimeters. And the MRI visible grade group 1s. There we go. My disclosures. This is a true focal therapy with our goal to eliminate the MRI abnormality plus a 1 centimeter margin. All of our patients get a 6-month biopsy at the treatment site, and then PSA density, follow-up multiparametric MRIs, and then PROMs, including the IPSS, SHIM, and mental health questionnaire, PHQ-9, that's done regularly. 85% of our patients are treatment naive, but we also have a salvage limb. I'm going to focus on the salvage limb in the interest of time. So patient age, not surprisingly, most between 60 and 70 years. Tumor location, not surprisingly, 72% in the peripheral zone. Gleason score breakdown, so about 60% are grade group 2, 27% large volume grade group 1, 16% grade group 3 in the treatment naive. In the salvage limb, we basically have treated, all previous types of primary therapy with all types of Gleason scores and all types of locations. In terms of PSA results in the treatment naive, about a 34% drop at 12 months, much larger drop, about 70% in the salvage patients at 12 months. The SHIM results, there's a little bit of a dip at 3 to 6 months. It usually claws its way back in the treatment-naive patients by 12 months. IPSS scores, a little bit of improvement we tend to see in these patients because of the decrease in gland volume, presumably. The mental health questionnaires, which I think are an important part of PROMs in the focal therapy patients, and those of you involved with these trials, I would strongly encourage you to include some of these mental health measures. Very, very stable throughout this process. And also, we don't tend to get the loss of patients like tend to occur with active surveillance. They're pretty good about returning for everything. These are the 6-month in-bore biopsy results on the treatment-naive patients. So 17% in-field were clinically significant, and that was defined as anything was pattern 4 or anything that's extended outside of the prostate gland. So the 3+3s, clinically insignificant, 17%. The clinically insignificants were just managed with active surveillance. Right or wrong, we're just going to pay attention to patient our outcome measures, which are metastasis-free survival and disease-specific survival. So if you look at all of the biopsy results over a 10-year period, so this would include incidence cancers and out-of-field cancers, the clinically significant jumps up over 23 years at the over 10 years at the treatment site to 23%. And over those 10 years, our out-of-field clinically significant prostate cancer that's incidence is about 4%. If you look at metastasis-free survival at 10 years, it's 99%, and our cancer-specific survival is 100% at 10 years. Interestingly, if you look at the initial PSA density, it's actually a predictor of the biopsy results, both looking here at just the treatment site, so the in-field recurrences. So PSA density of 0.22 or greater is a predictor of clinically significant disease at the 6-month biopsy, at a level of 0.17 clinically insignificant disease, and then a negative biopsy at the treatment site at 0.15. So to kind of summarize the results, 95% of our patients were biopsy compliant. So 95% of them got biopsies at the treatment site at 6 months. Clinically significant in-field recurrence rate was 23% over 10 years. The out-of-field recurrence rates that were clinically significant, 4%. Our conversion rate over 10 years was only 6% to whole gland therapy, so we had a 94% avoidance rate of whole gland therapy and its associated morbidity during these 10 years. The rate of prostate cancer-specific metastasis was only 0.8%. So with the initial treatment, we had really favorable oncologic control in 77% of the patients. And most of these patients whose in-field recurrence was documented elected retreatment with laser. So most of them didn't end up getting moved over to whole gland. Instead, they just elected to get what we call getting another haircut, going in and having a repeat laser. Now, if you compare our numbers with biochemical recurrence rates for radical prostatectomy and radiation therapy for intermediate risk, the numbers are not that far off the mark. 20% at 5 years and 30% at 10 years. We're right in those ballparks. So what are some potential solutions for the recurrence rates? Well, obviously, better treatment planning has been nicely addressed at this meeting with some potential solutions. The problem with increasing the margin size, which we have done, it increases morbidity, we find. We think that better risk stratification is important, including PSA density, what's happening in the genomic space, and other companion diagnostics. PSMA, we think, is going to be an important role here. And then, as I presented earlier, we think research in combination therapy is very, very important for moving this ahead quantumly to get rid of these recurrence rates. And we have found that over 10 years with, reasonable, Kaplan-Meier survival curves, that it looks like we can sort of convert, at least at 10 years, intermediate risk organ-confined prostate cancer into kind of a chronic illness where we just treat them intermittently with laser focal therapy. Thank you very much for your attention.